Hello everyone. Surgery is done in month of August by Orthopedic Department, Prasad Institute of Medical Science, Lucknow. Case 1. This patient was 26 years old female with fracture of mid-shaft clavicle right and managed by open reduction internal fixation by K-wire on 6th of August 2024. This fracture clavicle fixed by open reduction internal fixation by K-wire. It's sustained at the junction of lateral one third and middle 2/3 due to fall on outstretched hand, because this is a junctional area between the two curvature, flat and triangular portion, cancellous and cortical bone, two ossific nuclei, weight bearing and non-weight bearing portion of the bone. Sometimes the two ossific nuclei fail to fuse bilaterally along with failure of fusion of cranial sutures. The condition is called as craniocleidodysostosis, where the person can meet the shoulders in front of the chest. The displacement is downward forward medially is restricted if the coracoclavicular ligament attached to the proximal fragment is restricting it displacement. The reduction is by figure of 8 bandage with the bent of knee of the surgeon in the interscapular space. Complication is malunion. In this case, besides the anatomy of the clavicle must be remembered if open reduction is to be carried out. Case number 2. This patient was fracture of intertrochanteric femur right, managed by close reduction internal fixation by short proximal femoral nail. Abductors attached to proximal fragment abducted, adductors to distal fragment adducted. Thus, there is abduction and anterior angulation. This can be reduced by traction till over correction of the overriding and pushing the proximal fragment posteromedial and distal fragment anterolaterally. Rotation is corrected by the middle spike of the distal fragment aligned with the notch of the proximal fragment. In open reduction, linea aspera is used to correct rotational displacement. The position should be retained while passing guide wire, reamer or nail. Case number 3. 60 years old male with diagnosis of osteoarthritis knee grade 4, managed with diagnostic orthoscopy left knee. Osteoarthritis knee is due to loss of the glucosaminoglycans molecule which binds the hyaluronic acid to the collagen 4. Consequently, the water producing the shiny, smooth, compressible nature of the cartilage and responsible for its low coefficient of friction, 30 times more slippery than skates on ice. That means the coefficient of friction. The cartilage becomes pale, shrunken and fibrillar and is rubbed off, forming detritus, which floats in the further damage in the cartilage. This detritus is washed off by the orthoscopic lavage. Exposed shiny subchondral bone is called evernation, which microfractures on weight bearing leading to sclerosis and subchondral cyst in the non-pressure bearing areas. The cartilage gets infiltrated by blood vessels leading to osteophytes formation. Osteophytes are differentiated from syndesmophytes, which are calcification of ligament due to type 3 hypersensitivity reaction seen in ankylosing spondylitis, and because osteophytes are horizontal and syndesmoverticals in the last phase, the bone gets depressed leading to varus deformity. The line of weight bearing shift medially leading to increasing varus. The knee joint is by bipedal gait bearing twice the weight as compared to quadrupedal gait, having long lever arm on the hip, and the ankle side is further disadvantage biomechanically. Weight reduction, the further disadvantage biomechanically, weight reduction, muscle strengthening, depometal and PRP injections, and pain point arthroscopic lavage of the detritus cartilage, regeneration by glucosaminoglycans or growth factor injection, and correction of biomechanical by HTO or fibulectomy are a method of treatment to be considered before deciding TKR. Case number 4. The 34 years old male with fracture of proximal tibia left and managed with open reduction internal fixation by plating and CC screw. This 34 years old male presented with lateral condyle fracture of the tibia from intercondylar reach. Articular restoration has been done by compression lag screw and the lever arm fixation achieved by buttress plate. Case number 5. The patient 19 years old with anterior cruciate ligament sprain with posterior horn of lateral meniscus tear right, managed with diagnostic arthroscopy. So this 19 years old male presented with hemarthrosis and internal dearrangement of knee following injury 6 months back. Diagnostic arthroscopy was done to visualize suprapatellar pouch, articular surface of patella, middle compartment, intercondylar space, ACL and PCL, lateral compartment and popliteal recess. MRI was diagnosis confirmed and no intervention was needed. Case number 6, 18 years old male, also treated case of fracture distal end radius left, managed with open reduction internal fixation by plating 1 year back. So implant removal was done on 24th of August 2024. Case number 7, 17 years old male with fracture mid-sharp clavicle left, managed with open reduction and by TENS on 24th of August. This clavicle fracture medial to the attachment of the coracoclavicle ligament, where the ligament could not prevent the upward displacement of the proximal fragment, needed open reduction and internal fixation because the proximal fragment penetrated the skin, making it an inside-out compound fracture. After an incision dividing skin and platysma over the fracture site, the fragment were exposed by removing the trapezius from the posterior border and pectoralis major from the anterior border. TENS was passed from the medial side, fracture reduced, and the TENS was advanced into the lateral fragment. Case number 8. This patient was 75 years old female with unstable intertrochanteric fracture was fixed by dynamic hip screw and plate. Case number 9. This 40 years old male presented with open contaminated wound with fracture of first, second and third proximal phalanx of left foot with tendon injury, managed by cross K-wire in first proximal phalanx and followed by single K-wire fixation of second and third phalanx and tendon repair. Case number 10. This 19-year-old female had fractured neck of femur and managed by dynamic hip screw with derotation screw fixation on 21st of March 2023. History of fall leading to pain in the operated hip, so implant was removed and now patient is pain-free. Case number 11. The 70 years old male patient sustained injury to left leg leading to open contaminated wound with Castillo-Anderson classification type 2B with segmental fracture of tibia and fibula. The patient was treated by debridement of the wound, reduction and fixation by the external fixator. The last case, case number 12. This 25 years old male presented with severe infection of the knee leading to acute painful weight bearing. He was treated by orthodesis of the knee with lateral and anterior plate fixation. Anterior plate is stronger in valgus and varus strain and lateral plate is stronger in flexion and extension plane. Thank you so much.